I'm Tom Hoppe, and I'm your host of the Most Painful Podcast. Research has shown veterans suffer from chronic pain at twice the rate of the civilian population. Many veterans I know and many listeners to the show suffer from back pain, and many have asked, does surgery help with back pain? Or are there other therapies that may help with back pain versus surgery? To help answer this question, I'm joined by Dr. Brian Drew, a spine surgeon. Welcome to the show, Brian.
Thanks for having me.
Before we get into the conversation, I just want to let our guests know that we're going to have an announcement for a gift at the end of the show, so please stay tuned. So, Brian, I think back, and you and I talked about this offline a little bit, and it kind of really struck me when I was at a veterans reunion. It was an overseas tour. We had a reunion. I'd say about 3/4 of the veterans there all had some form of back problems. Some had surgery. Some were told surgery doesn't work. They should do physical rehab. And so it seemed there were a lot of mixed messages. So when it comes to back surgery or spinal surgery, can you give us an overview and then what's involved and what a candidate may be?
Sure. I can give you kind of a rough overview that we'll have, and then I can go over exceptions to all the basic rules I'm going to paint, because there always are exceptions. And spine surgery in general has some fairly black and white areas where it's easy to decide whether someone is non-surgical or surgical. But unfortunately, there's quite a bit of a gray zone as well. But I would say in general, if we're just sticking to the lower back, there's really not much we do from a surgical perspective for back pain. So I tell my patients, if I'm doing an operation on your back, primarily to help leg pain. So if you have a pinched nerve with pain running down your leg, often, it's called sciatica, at least in the younger population, and you have quite bad leg pain, and an MRI shows there's a pinched nerve that's in the same distribution of the pain in your leg, because we all have that mapped out fairly well, kind of like, how your house is wired, right? You can go to the fuse box and this wire goes to the bathroom, this one goes to the kitchen. In the back, there's kind of a fuse box, and we know, this one goes to the front of your leg, this wire goes to the side of your leg. So all that has to kind of match together, and that operation is to release pressure on the nerve, and that helps your leg, but it doesn't change your back pain.
So is that why some are referred to rehab and do not have surgery? Is it dependent on how bad it is for their leg pain, or what happens if you have I guess it's the facets that pinch off the nerve that branch out to the legs, or to parts of the body, I guess, in a sense, right? Is that correct?
Yeah, the facet joints, if they gather some bone spurs in the right location, that can pinch on a nerve. Also, discs can herniate out, especially in the younger crowd, younger being kind of 50 and under. Although again, there are exceptions. People have disc problems later than that they can push on the nerve as well, and we would trim the disc off or trim the bone spurs on a facet. Sometimes it's a bit of both. If it's purely disc, probably 90-95% of acute disc herniations will get better on their own. So if you give it some time, give it some type of rehab, chiropractic treatment, physiotherapy, they'll get better on their own. So we don't want to jump in and do surgery, because it has risks associated with it. Even though for that condition, it has a fairly high success rate, we don't want to do it unnecessarily, when if you just give it some time, control things with some medication, some rehabilitation, it'll get better on its own, and you avoid surgery. If it's more degenerative in nature, i.e. kind of the bone spurs on the facet joints, and you tend to develop that problem kind of over 50, that tends to not go away with rehab and slowly worsens over time. Kind of like an arthritic knee. You get a bit of arthritis, you don't jump to a knee replacement, but slowly over time that could get worse. And then if your leg or legs start to bother you, then usually rehab doesn't work as well for that, although we usually give it a try, because a few people will respond and perhaps delay surgery. So it depends on what the cause of the disc or the cause of the nerve compression is.
When you say that it doesn't take back pain away, so someone has low back pain, now their leg's better, but they're still going to struggle with back pain. Why is that? Why wouldn't it repair it?
Yeah, it's a good question. And back pain, determining the exact pain generating structure, because our brains you take a step back and look at the way our brains perceive things, it's called, the fancy name is called the homunculus. And if you think about how well you can feel things on your hand or your face and tongue, you can really discriminate very specifically where someone is touching you with a needle.
Mm-hmm.
But in the back, that area of our brain's pretty small and it can't differentiate things. It can tell you, hey, my back hurts, but it can't tell you if it's a muscle, a disc, a ligament, a broken bone. Just as I kind of hurt in that spot. And then the spine is even more complex because there's different levels. You heard there's like L3, 4, L4, 5, L5, S1, and trying to figure out exactly what specifically causing the back pain is difficult. We don't have a test that does that. We have MRIs that show us a really good picture of the spine, but it doesn't tell us what's causing pain. So we need to kind of invent, I call it a pain scan, where we could put someone in a machine and it tells us where their pain is coming from. It would make my job quite a bit easier, but that doesn't exist at this point in time. So we use X-ray, CT scans, MRIs, and more importantly, what we're hearing from a patient when we talk to them and when we examine them, and we kind of put all those tools together to try to determine perhaps where their pain is coming from. And, pain can come from a disc that's deteriorated. It can come from an arthritic facet joint. It can come from some muscle imbalances. When we do surgery, we don't fix the whole disc. We don't fix the arthritic facet joint. We don't fix the muscle imbalance. We can just focus in on that nerve, release the pressure on it, and help the leg pain. But the rest of that disc is still degenerative. The rest of that facet joint is still arthritic, and that goes on and continues to produce back pain. It can get confusing. One of your other comments you made was at the beginning, and I thought, and it's so true, where people go in and say, well, this guy got surgery and this guy didn't get surgery. And the MRI says, I got an L4-5 disc. Just like you. And yeah, I had an L4-5 disc, right? So their MRI tells them something, and so they're the same as their buddy or their friend or whatever. So therefore they should get the same operation because it worked really well for the one person. And then, my doctor told me, no, surgery isn't going to work, and it's confusing to the patient. And so, we're looking at it from a surgeon perspective, right? We're asking, again, if I stay really kind of basic, let's call it, you have an L4-5 disc. And I ask you, I say, well, how much pain is in your back and how much is in your leg? And if you said, well, 90%'s in my back and 10%'s in my leg, then I know my operations at best, if it works 100%, is going to make 10% of your symptoms go away. You could have the exact same disc herniation and the person will answer the opposite. They'll say it's 90% in my leg, 10% in my back. That person is a way better surgical candidate just on that one question without even examining them yet. And then the MRI is important. The MRI might show a disc bulge, but discs can bulge a ways and not quite hit the nerve. Other times they can bulge bigger and clearly hit the nerve. And so even though both persons have a bulge, it can be various locations and sizes that make surgery indicated or not indicated.
And I can see how that is confused. Well, experienced it too, because if you got a room full of guys and they're young, guys and girls that are young, and I don't know if it's because of our job that we're doing or, the culture of being numb to pain, you just push through. They all have either, C-spine issues or low spine issues, and they're comparing notes, right? My doctor said this and my doctor said that, and well, I got this and that worked. And one guy I talked to said, yeah, they rushed me into emergency surgery because I couldn't feel anything, And so it's confusing. I can see how that is an issue, right?
Yeah, it is very confusing. And it's, we, for all the back problems out there, we warn people about, what's an emergency or what's more urgent than others. And there's not a lot of urgent stuff. But again, someone has that disc herniation and now it's so bad. They don't just have pain, they have weakness that's developed. So they have a muscle that's going paralyzed and their foot's dropping down and doesn't work, or they can't lift their heel off the ground. And if that happens acutely, sometimes going in surgically to decompress it sooner than later can help save an important functional muscle group in your leg. Same with bowel and bladder function. If you start to get numb through the genital area and through your bum, basically, then you could lose control of bowel and bladder function with a big disc herniation, and that's a surgical emergency, but fortunately quite rare.
You hear guys say, "Oh, if I wouldn't have got that done, it was permanent. I had to be in a hospital within an hour or something like that." Is that true? Is it permanent that when you have bowel
with the bowel and bladder symptoms?
Yeah.
We call that cauda equina syndrome is the medical term for that. And there is the scientific evidence is a little bit mixed on it, but probably the best evidence we have would be somewhere between 24 and 48 hours of the onset of symptoms, clearly with a very large disc herniation that's affecting the nerves that control bowel and bladder function, that decompressing those in that short period of time gives you the best chance of regaining as much function as possible. And if you go past that timeline, getting that function back drops considerably.
Would you suggest that somebody like that has probably already been followed prior to that and probably, they've seen the degeneration path kind of moving forward? Or is it all of a sudden, like they would have probably had back problems prior to this, right? Is what I'm trying to say.
They might have. There's the odd, young, healthy person, never had a problem in their life, and they're doing some super heavy deadlifts or squats or some kind of unusual thing that blows this acute disc out, and the disc material fills the canal so much that there's no warning and they were perfectly healthy. So that scenario does exist as well. Other times people can have chronic disc problems of various size disc bulges, and then something happens that pushes that disc out into a larger size and then changes the clinical picture a lot. So if someone comes into the emergency room and they have bad leg pain and sciatica and they're struggling and it hurts, it's an extremely painful condition. And again, it can vary, but it can be quite severe and debilitating. And they're told to leave with some medication that they're not going to get fixed. Because again, 90 to 95% of those people are going to get better over time. But they're warned, hey, if you develop these symptoms of cauda equina, come back here right away, because then we have to do something about it immediately.
You had mentioned that, degeneration, not just a bulge, but degeneration eventually will possibly lead to surgery. But in the meantime, what are some things that people can be doing? I mean, we know rehab and that, but does strengthening muscles and safe movements actually delay that process, or is it eventually you're gonna end up having surgery anyways? It doesn't matter how hard you work out or how hard you strengthen your core and that kind of thing, or is it going to happen anyways?
Well, with the degeneration, we know there's degeneration that's going to happen, and then there's going to be symptomatic degeneration, right? So just like our skin is going to wrinkle as we age and we're going to lose hair, it's going to go gray. That's not hair disease or skin disease. That's just normal aging of our bodies. And our spines are going to do the same thing, right? We're going to get some bone spurs and arthritis in our facet joint and some degeneration in our disc. And if you take an MRI of a person every 10 years, they're totally asymptomatic and have no back pain. Each MRI is going to look worse every 10 years. Just like we have to say to ourselves, if we took a picture of ourselves every 10 years and laid them out, we go, yeah, I'm getting worse. We're getting worse every 10 years.
Yeah, I'm losing my hair every year.
Yeah, me too. Glad it's a podcast. So we know that degeneration is going to happen for sure. Being symptomatic and then going on to have back pain, that doesn't happen to everybody. And the degree of back pain we have doesn't correlate very well with the degree of changes on the MRI. So some people have more minor degree of back pain and a pretty bad looking MRI, and vice versa. And we see that with knee arthritis and things like that too, although not maybe to the same extent in spine, because the spine's a little more complex in its anatomy and pain generating structures. But and probably we would never go on to do surgery in that person and anybody unless they started to develop the leg symptoms. And for the degenerative stuff that's going to happen and eventually pinch a nerve in your leg, that you might have an operation in your 60s, 70s, 80s for, it's often called spinal stenosis. That's a degenerative pinched nerve versus an acute disc herniation that's in the younger crowd. That's probably going to happen, and there's not a lot you can do about it. But when you have back pain in your 20s, 30s, 40s, and there is some degeneration there are things you can do about that to try to help there's not one perfect scenario I could describe that you should do. Probably keeping your weight down is a good idea. Don't start smoking. And if you do smoke, stop smoking. On the long list of reasons not to smoke, no one talks about back pain. We always, it's cancer and heart disease and stroke and that type of thing. But having nicotine floating through our system does impair the ability for our discs to heal. So we all do things in life and, lift things, and we do get these little microscopic injuries, and they sometimes heal and sometimes don't. And the blood supply to the discs isn't very good to begin with. And when there's nicotine in our system, that decreases the blood flow in a microscopic fashion and can potentially prevent some healing. So if you are smoking, stopping can potentially help mechanical back pain. Learning to lift. So if you're a bit of a sloppy lifter, that having the right type of body mechanics if you do have a lifting type of job to do would be important to do. And, chiropractors and physiotherapists and, some personal trainers are quite knowledgeable in that area. So that's helpful. And probably keeping some good core strength is helpful as well. After that, it gets into, you could probably list a bunch of other things if you talk to a bunch of physiotherapists and chiropractors. I used to be a physiotherapist before I went into medicine. And so I say it from love, but it gets a little mucky because everybody's hamstrings are different tightness and pelvises can be malaligned and your hip flexors can be pulling on something. So if you go to enough of those people, patients, again, hear a lot of different things that's wrong with them from well-meaning and well-educated and very smart allied health, as we sometimes call them. And they're awesome. And I send a lot of my patients out to those folks because they can do a good job. I tell them, if you go see 3 different physiotherapists or 3 different chiropractors, you're probably going to get 3 different answers, but probably buried in their assessment, there's going to be a lot of overlap that's the same. And then what you hear and take home is going to sound a little bit different.
Yeah. And I think of my own journey too, is commitment is a big piece. I mean, like you said, the diet, all that good health and wellness stuff and fitness and core and safe movement, but it's also sticking to it too, because it's a lot of hard work, but like you say, how else do you keep strong and moving? Because I mean, as I've always heard, and if you sit around, your chronic pain gets worse. And then, people don't move because they say it hurts, but they should actually be moving in the first place anyways.
Yeah. And that's it's that downward spiral, and exercises at some point don't make you feel better. And so you stop doing them, but they're stopping you from getting worse by doing them. And it's a slow change, and it's sometimes imperceptible, and you don't realize it. And it takes work and time. And frankly, a lot of core strengthening exercises are kind of boring, right? And if you can find a fix, you look for it, whether that's a pill. And there are dangerous pills out there people take chronically, and sometimes you can get offered surgery for borderline types of conditions because MRIs look bad, but symptoms don't quite match. And that happens a little bit. And there's lots of people with, we call it failed back syndrome, where they've had 1 or 2 surgeries and it hasn't helped their condition. And that leads to chronic problems as well. So we try to reserve surgery to areas we think can really make a difference. And there are some of those, but unfortunately there's a lot that surgery can't help. Rehab can. There are other procedural types of things we can chat about if you want to that can sometimes help back pain that surgery can't help.
And, we could go on for a long time because there's a lot of good information you've brought up. I've learned a lot. And, but unfortunately, we're running out of time. So and that's what we're finding with our podcast is there's so much information. And I think the key is, from what I hear you saying too, is people have to educate themselves too before they go in and understand the best they can on what they're getting themselves into. Once again, we're just scratching the surface of the whole thing. So I'd like to, thank you for being on the show, Brian. That was great. Maybe we'll have to do another one. I think I keep saying that to all my guests because you just get started and it's like, geez, there's so much to learn here, and
well, we could chat again another time. And there are a few other things, and that pain clinics can help out with and things like that. Maybe we can discuss another time.
Yeah, for sure. And so I'm just going to close off the show, and thanks, Brian, for being here. But so, talking about pain, the next show actually we're doing is on psychedelics. So for our listeners, they'll They'll know, the psychedelics help chronic pain. We'll talk about that next. If there's any feedback for the show or you want more information on chronic pain, you can visit the website, chronicpain.ca, or follow us on Facebook and Twitter at Chronic Pain COE and on Instagram at Chronic Pain_COE. So just that offer and that we're going to give away. And I don't know if you know him, Brian, but Dr. Peter Attea, he's a Canadian doctor, is in the U.S. He has a really good podcast on health and wellness, a lot of evidence-based information that I found very helpful over the years. And I think some of that will help our veterans, especially with the culture change. So they've offered first 10 people, they offer a free subscription to his site where there's lots of access to health information. And if you want to have access to that, just send us your email at chronicpain.ca or on Facebook and Twitter at Chronic Pain COE or on Instagram at Chronic Pain_COE. Once again, thank you, Brian, for being on the show. We're definitely going to have you back again in the future if you have time.
Oh, my pleasure. Thanks for having me.
And to our listeners, stay well. Thank you.
The Most Painful Podcast is produced for the Chronic Pain Center of Excellence by Story Studio Network and Eye Contact Productions.